Welcome to the deep dive. Today we're jumping into a really foundational topic, the Papa-Nicolau test, better known to almost everyone as the Pap smear.
Right. And our sources, well, they really map out this incredible evolution. It's hailed, quite rightly, as a massive win for preventative medicine in the 20th century. But the story now is about its transformation into this modern molecular-based way of assessing risk. That's what we want to unpack.
And here's maybe the most fascinating part, why it's so impactful. The Pap test works because it catches problems before they become cancer. It finds those very early precancerous changes. That's how it's drastically cut the global burden of cervical cancer.
Exactly. It allows for intervention when the pathology is just starting.
Okay, so let's get into the mechanics. How does it actually do that?
Well, the key is that cervical cancer, thankfully, usually has this long, slow lead-up phase. Clinicians call it cervical intraepithelial neoplasia, or CIN. It's basically abnormal cell growth.
And finding that, the CIN, lets doctors step in.
Precisely. If you identify and treat those CIN cells, you can prevent invasive cancer more than 95% of the time. It's incredibly effective.
Wow. Okay, and successful testing depends on getting the sample from the right place.
Absolutely critical. It hinges on sampling what's called the transformation zone, the T-zone.
The T-zone.
Yeah, think of it as this dynamic area on the cervix where the cell types change. It's the hot spot.
Right.
This is overwhelmingly where those abnormalities, the ones we grade like LSIL or HSIL, tend to arise.
Right, low-grade or high-grade changes. But here's where things get really interesting and maybe a bit surprising for some listeners. The vast majority of these cellular changes, they're actually caused by HPV.
Exactly. Persistent infection with certain high-risk types of the human papillomavirus. That's the root cause in most cases.
So the Pap test was kind of looking at the symptom, not the virus itself.
That's the crucial distinction, yes. Historically, the Pap test is an indirect screen. It detects the cellular consequences of HPV, the damage. A separate molecular test directly detects the high-risk viral DNA.
And that difference drove this whole modern shift in screening, moving from effect to cause.
Pretty much. Because looking for the cause, the high-risk HPV DNA, turns out to be, well, a better primary screen.
How so? Better how?
The data's really clear on this. Primary HPV screening, just testing for the virus first, has much greater sensitivity. It's better at picking up who's potentially at risk.
Which means you can be more confident if the test is negative.
Exactly. A negative high-risk HPV test is incredibly reassuring. That's why major guidelines, like from the American Cancer Society, now prefer primary HPV testing.
And they recommend it less often?
Typically every 5 years for women aged 30 to 65, yeah. Because that negative result provides such strong assurance for a longer period.
So where does that leave the Pap test now? Is it just gone?
Not entirely, but its role has changed. It's often used as a triage tool, meaning if the primary HPV test comes back positive, then you might do cytology, the Pap test, to see what the cells actually look like. Is there damage yet?
Okay, that makes sense. Let's talk about results then. An abnormal Pap can sound scary. How are results reported, and what do they really mean?
So all the results are standardized using something called the Bethesda system, TBS. It gives us categories like ASCUS, LSIL, HSIL.
Which are the low-grade and high-grade changes we mentioned.
Correct. But the key message for patients, an abnormal result indicates risk, not a definite cancer diagnosis.
That seems really important to emphasize.
Hugely important. Abnormal PAPs are actually relatively common, maybe 3, almost 4% of tests. But invasive cancer following an abnormal result, that's rare, fewer than 1%.
So it triggers further investigation based on the level of risk.
Precisely. It leads to risk stratification. And this is where age becomes really important in deciding the next steps.
How does age factor in?
Well, take younger patients, say 21 to 24 years old. If they have a low-grade abnormality, like ASCUS or LSIL, the management approach prioritizes surveillance. We usually just repeat the cytology, the PAP, in 12 months.
Wait. If something's abnormal, why not just treat it immediately?
That's a great question. It's because in younger women, these low-grade changes and the underlying HPV infections very often resolve on their own. Their immune system clears it.
Ah, okay.
So we want to avoid unnecessary procedures, potentially invasive ones like LEEP,
Right.
loop electrosurgical excision procedure. It removes the abnormal tissue. It's effective, but it's not without risks. It can sometimes impact future pregnancies, like increase the risk of preterm birth. So we balance the small risk of the abnormality progressing against the risks of intervention.
Minimize potential harm from overtreatment, essentially.
Exactly. We watch carefully, and this is a big, But if the finding is high grade, like HSIL or another serious category called AGC, that warrants immediate action.
Regardless of age.
Regardless of age. High-grade findings mean a higher immediate risk, so that patient needs a referral straight away for colposcopy.
Which is a more detailed look at the cervix.
Right, a specialized examination.
Okay, this really clarifies things. So the core takeaway seems to be the Pap test isn't obsolete, but it's now a key player within a broader system, a system that's really driven by molecular testing first, looking for that high-risk HPV.
That sums it up perfectly. It's moved from a standalone test to being part of a smarter, risk-based strategy.
Which leads to a really interesting final thought.
Yeah, something for you, the listener, to consider. We're seeing this global push towards eliminating cervical cancer, right? And the focus is squarely on HPV vaccination and primary HPV screening. So given that shift, maybe it's time to rethink the name. Should we perhaps retire the term pap smear and maybe adopt language that better reflects this comprehensive HPV-focused molecular prevention strategy we use today? Just food for thought.